Jose. How are you doing?
Good morning. How are you? Doing good.
All right. So hopefully you're up and early.
Tired from the party last night.
Well, I know. I guess the wine was too good.
You bet
All right.
it was.
So let's see. So what do we have for us today?
Okay. Let me introduce our team. We have on my right side, right here, we have Dr. Yuhei Kobayashi. He's our junior faculty who has expertise in physiology and intravascular imaging. We also have our interventional fellow, Nicolas Biakos. We have our interventional radiology fellow as well, Usman Shahid. We have our CVT tech, Michelle Blanco, back in the control room. We have Brenda Solis, our nurse, which is back here. And we also have our other nurse, Moody Bennett, who's a new addition to our program. Next slide. So let me tell you a little bit about this patient. This is a 62-year-old gentleman with a past medical history of hypertension, hyperlipidemia. I don't know why I repeated hypertension twice. Peripheral arterial disease, status was right BKA, multiple stents in the left SFA. Patient underwent a left femdistal bypass and was referred for left lower extremity resting pain. Past medical history as above, surgical history left femdistal bypass. Actually, bypass goes to the perineal. Family history is not contributory. He's a current cigarette smoker, no ETOH-related drugs. Aspirin, the usual aspirin, beta blockers, ACE inhibitors, statins, cilostazol. This is another patient that did not tolerate. And I wonder if you guys are having the same problem that I'm having, patients not tolerating cilostazol. Physical examination, vital signs are remarkable today and when I didn't before. Physical examination is significant for right DPPT of +1 and the left dorsalis and posterior tibialis +1. Right ABI, it's a mistake from a previous slide. There's no ABI on the right. On the left was 0.72. Okay, let me show you the prior films. Can you see this?
Yes.
Okay, can we run it, please? Next, guys. Next. There you go. Okay, so you have a left iliac stent. The left SFA is occluded. We have a fem distal bypass to the perineal with single vessel runoff down the perineal. Can you show the next picture, please? I believe we have the runoff down to the foot. Next. 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 There you go. No, go back again. I'm sorry. Play it. There we go. So we have a tight anastomotic lesion, which I'm interested in listening to comments from the panel because it's right at the anastomosis of that vein graft to the perineal. I have an idea of how I want to treat it, but I want to listen to you guys. What's your approach for bypass anastomotic lesions into a single vessel runoff?
All right. So we'll start with the surgeon, Dr. Kratzy. What do you think?
So yeah, it's a good question, Dr. Wiley. It certainly start with a balloon, but you always have the expectation there's a recoil. The problem I always face is if you're going to line it with something in terms of stents, there's size discrepancy from that bypass, which you can see, to the target vessel. So if you land a little bit proximal, creates turbulence, and a lot of times you see them go down. So it would really be the balloon, certainly a drug balloon, and herniating it through, but not too much into the perineal side. Perineal looks okay, although there's some distal disease. And then if there's a recoil, it's anastomotic. I'm not a fan of atherectomies. I know people do that, but I would stent it, but parking the back end of the stent as close to that suture line without herniating into the bypass as possible.
I think that's a good
Yeah,
option.
so I have the same concern. Anybody else on the panel that has any take home, or should we use some sort of atherectomy, laser,
Do you have a DSA image of this, Jose? Do you have a DSA image of the anastomotic side?
You know what? If you want to do one, let's go there. Yeah, let's do.
Because there is a bone
Somewhere
overlap
around
there.
here.
You want to probably have a better idea how that looks.
And you probably need to
Yeah.
separate your tibia and fibia more. But my go-to on anastomotic lesions is balloon angioplasty. But of course, you determine the age of your
PSI, guys?
anastomosis. You want to be very careful with acute anastomosis, which this is not. Otherwise, you tear suture
It is
lines,
not, yeah.
but you will.
I'll be
Uh,
concerned about the
situation.
mid-perineal vessel because angiographically it looks at least moderate disease, and another imaging modality such as IVUS I think will shed better light because you can definitely see a discrepancy between the size of a mid-vessel to the proximal perineal
Yes, sir?
vessel.
Yeah, and I would echo that because you can see the hang up of the contrast in the
Right.
bypass. The outflow is not great.
There you go. So there's clearly a little discrepancy in the caliber of the perineal. Not as much as I thought, but we have IVUS here if you guys want to.
So you can definitely
try it.
IVUS this and see what you are dealing with, and maybe consider either scoring or cutting balloons there. It depends what IVUS shows.
Any concerns of you using cutting or scoring in a vein graft?
Not
Alfio,
really.
do you think about it? You're okay with that?
I think you will learn a lot from IVUS, and it will show you what you're dealing with, and it will be easier to figure out what would be the best strategy to address that.
Yeah, this is a large perineal vessel.
So,
I mean,
Lamar?
you will probably end up with a 4.5.
Give me a
Or
300.
let's see what IVUS shows. Even 5.0 at the junction, depending on what the IVUS shows. But this is look at the caliber of the after the anastomosis compared to the distal portion of a bypass. So it's
Yeah.
not as
And then
small
the
as
next
what I think.
question, if we're going, yeah. So then the next question is how far we're going to stent if that's what you guys want me to do.
I think an IVUS should give you a very good idea of where besides the anastomotic lesion, if the distal, the lesion after the anastomosis, there is some degree of calcification and lesion right there, so you can really define it with it, and probably then you can mark your
Okay.
lines on it.
Okay, let's try to do it. Well,
So is
while I'm
anybody-
wiring this,
Anybody a
Um,
fan of distal protection with
Yeah.
an
I
anastomotic
was going to
lesion?
ask that question. That's true, Doctor. Anybody, Dr. Lee, would you use a filter, knowing that it's just one vessel and the physiology is still to be ascertained by IVUS?
Yeah, I mean, I think obviously will show us a lot, but single vessel, if you're thinking about it, it's always the right answer to do it. Now, was this a claudicant, or was this just a graft surveillance, or was there a wound? I missed that part.
no, this guy was having resting pain, and
Resting
we've done every sort of testing, and nothing comes out suggestive of anything else other than this. So likely that anastomotic lesion is worse than what we're seeing in two-dimensional imaging here. So
How old
hopefully
is this bypass graft,
the-
Jose? How old is this? When was the surgery done on the left leg bypass?
yeah, 5 years ago.
5 years ago. Okay.
Mm-hmm.
So yeah, my only comment was the size mismatch. A lot of times is a lot more severe. Here, it's actually almost the same to me.
Yeah.
But and then I agree with Fadi on the mid-perineal lesion. But if it's rest pain, I probably would leave it alone or look at it after we
We do
finish
that,
the
yeah.
anastomosis. But if it was
take some contrast
critical
first.
limb, then obviously
Do
do
a
something there.
fluorofade.
You know, what attractive
So
part
are
about
you
leaving
guys,
nothing behind is the amount of collaterals that's coming off of the vessel. I mean, obviously, any scaffold, it's not like a closed cell stent design, but still, you know, with the amount of collaterals that when you take the angio, it will be nice not to leave any scaffold behind. I understand there's pros and cons, obviously, to both approaches, but just think about it. Yeah, I mean, look at the contrast. Wow, thing. look at the die hanging right there.
Yeah, agreed.
Yeah.
On that comment, also, even retrograde, you had a big branch, couple
Yeah.
of branches coming off. If you lose that backflow upstream, it's going to be impactful.
That's
So-
true.
And while you could guess it'll stay patent, a lot of times if there's calcium, it'll shift and it won't.
All right. So, Jose, why don't I let you wire this and start with your IVUS, and we'll start
Yep.
at least with the first lecture, and then we'll catch up with you again.
Interestingly enough, it was a little challenging to get that wire down the perineal. That lesion there seems to be a little tighter, so we had to use a Carabel microcatheter that we use for many of our coronary work. But we finally got our 014 wire, and we're doing IVUS at this time, and I'll show you shortly. Can the camera show the? Are you guys seeing the ultrasound?
Yes.
The IVUS? Okay. Flora, let's see where we're at.
That's the question.
Okay.
Jose, question. It's Alfio
Yep.
Croce. The when you see stagnation in the
Alfio.
vessel like that, where do you keep your ACTs at while you're working? This is my
We're over
my
300.
over 300.
Are you
What is
heparin or
our ACT,
Angiomax?
Brenda?
Jose. Oh,
345, Angiomax.
Angiomax. Okay.
Yeah, the reason I use Angiomax is because I frequently forget doing ACT, so I feel more comfortable using Angiomax. But I want to keep it over 300. Okay, I think we're in the bypass graph, right? Okay, yep.
Okay. Do you want to show the slides first, or you want to?
Sure. Can we put the slide on again? This
Yeah,
time
slide
we're
on the
not
IVUS,
using the
please.
phase array. We're using the rotational.
Yeah, let me quickly
device.
go through. Yesterday, the case we are using iliac stenting, so that's why we use phased array 20 megahertz IVUS, which is resolution is low, but penetration is good. So that's why it's good for like larger vessel. But this time we are doing much more smaller REs. So we are using Boston Scientific 60 megahertz rotational IVUS, as you can see in the above. And then that is like higher frequency, which means high resolution, beautiful pictures, but has low penetration, so which is suitable for smaller vessels like this. Go to the next slide. Again, penetration and then resolution is a trade-off. If you want to have like beautiful pictures, but you lose penetration, but vice versa. Go to the next slide. So which we have like, a couple of representative artifacts in these slides. As you can see on the left top, that's the air within the IVUS catheter. Because like, this specific rotational IVUS catheter, which is IVUS imaging core is rotating within the shaft. And then you have to clear the air and blood within this shaft very well. And otherwise you won't get the beautiful image like that. And then go to the right top. This is the like white line from like 9 to 12 o'clock. That's the calcium. And then, usually you don't see anything behind the calcium because, ultrasound beam will not penetrate beyond the calcium. But if you see like, pseudo image behind this calcium, this is so-called multiple reverberations, which is physics of the ultrasound. You sometimes see this pseudo image behind the calcium or sometimes behind the stent strut. And then you go to left bottom. This is so-called NARD, NURD. This is the abbreviation of non-uniform rotational distortion, which will happen because this IVUS cath, this rotational IVUS cath is keep rotating within the shaft of the IVUS cath. And then if you don't make the IVUS cath straight, or if your IVUS is going through the very tortuous vessel, you will see this non-uniform rotational distortion. And the final one on the right bottom, as you can see, these are guide wire artifacts. So obviously in this particular system, you have to put the guide wire, and then the imaging core is running next to the guide wire. So you always see the guide wire artifact in this particular system. Okay, go back to the IVUS image, please.
All right, let's look at
So
the.
yeah. Enlighten us and tell us what we're seeing there and the sizing.
So this is the IVUS we just got. So obviously IVUS is printing back from the distal to the proximal. And then let me go over from here. So that obviously this is the arterial structure. We should see like intima media adventitia. But in this particular case, super calcified, these white, you can see it. These white things are all calcium. You can really see behind. But actually these images are probably multiple reverberations, like kind of shoot image from the calcium. And then we can't really know what's the vessel size clearly, but in terms of lumen wise, it's like 2.8 in terms of lumen size, but really calcified. Actually, we don't really appreciate from the angiogram. So let me go more proximally. Here, I would say we can see more vessel structures. These black bands are most likely media of the RE. So then I would say vessel size here would be something like 3.2.
Mm-hmm.
Okay.
Yeah, something like this. And then let me go more proximally, and then pretty much calcified plaque, and then again, like, calcified plaque. Let me go proximally. I see somewhere here, these are probably anastomosis site, as you can see, and then go into the venous structure. So this is a very distal part of the venous graft. It's a pretty tight stenosis. Doesn't look like very calcified here. And then proximal to it, this is the venous graft, which the size of the venous graft is about 4 millimeters. So it's not that much vessel size discrepancy. I think 3 in the RV, and the venous graft, it's like 4-ish vessels. So maybe we can post dilate proximally.
So we could use a 3.0 drug coated stent and then post dilate with a non-compliant in the graft.
Sounds good.
Jose,
Is
let me
everybody in
ask
agreement
the
with that?
panel.
Yeah.
So based on the IVUS finding, you see there is calcification in the native vessel, but the anastomosis, as we expected, doesn't have much of calcification or a thrombus or plaque. It's more fibrotic. Would you use any adjunctive therapy, or just straight go up with your definitive whatever PTA or DCB or DES? Any adjunctive therapy, meaning like atherectomy? Any of you? Dr. Lee, Dr. Jenkins, yeah.
So that would depend on your stenotic measurements in your native vessel, and if it looks correctly to me, it doesn't appear that you have a need to do a lot of work in your native vessel, correct? What was your lumen size there? Maybe go back to the lumen on your ultrasound in your native vessel.
It's
So
about 3.0.
that's what I would use to
was like
determine whether I'm going to use a calcium
2.8
plaque
distal.
modifying therapy versus not. An anastomotic lesion, I agree completely. This is a fibrotic lesion. The only thing I see you not doing that I would do, Jose, and maybe I haven't seen that,
Filter.
is a filter. So I think
Yeah. You know what?
it's
Give us a bare wire, please, and
thank
a
you.
filter.
Anybody else? Any
So you touch these lesions, you embolize. I know this is a fibrotic lesion, anastomotic, but there's acute
long bare
and
wire,
chronic
and I want a
problems in this
3.0,
anastomosis. And
3.0
I can tell you,
filter.
if you cut it out and dissected it and put it on a microscope, you would see thrombus. So you had very poor flow. I protect all of these.
agree,
and
Steve.
Think it saves time later.
Every
I
time
would caution a little bit of in the Boston Sci IVUS is a great tool, but sometimes it's hard to distinguish the hypoechogenic layers. So it's very nice for the calcium. But the other thing here was the stagnation. I mean, you're probably dealing with a little bit of underestimation of a true lumen of a vessel. So this is not a 3 millimeter vessel proximally. It is definitely larger, and between 3 and 4 millimeter, that's 25% difference. That's a big difference for these patients. The fact that this is an old bypass and there is some fibrotic tissue there, I'm not committed to placing a stent in there. So maybe using a plaque modification technology or even a DCB, albeit there's debate about the value of DCB within these areas, I think will be extremely valuable. I would favor not putting a scaffold in there for the purposes of preserving all of these, very rich and important collaterals.
Dr. Lee, any thoughts?
Yeah, trying to send this as initial approach or strategy. I'm not sure about this. I would I definitely put the filter down and probably use some cutting balloon to start with of this short segment and see what result you get. In terms of using drug-coated balloon there, if your vessel is truly 3.0 or 3.5, whatever they measured, the smallest you have is 4.0 balloon drug-coated. So that you can either, maybe go to very low atmosphere and see how that goes, but not sure.
Jose, so see some doing plaque modification. What did you do?
No, we just we're trying to get this filter, and we try to get a bare wire. It came back, so I'm trying to put a bare wire back in again, and then we'll put a filter that I like to use the Embold shield because it's independent from the wire.
Mm-hmm.
It's a little more tedious to get in, but I think it's a good idea to have it. Because when we're advancing balloons and stents and all that, they tend to move back and forward. And, if I have clot, it's the easiest way to lose thrombus within the filter.
So Jose, do you have a Wirion filter in your lab?
No.
I thought you were having trouble getting across your filter.
No, I got in. What happens is that the bare wire came back.
Oh.
Okay, let's put the bare wire in. So the bare wire is the one that has a transition that will hold the Embo Shield filter without getting it lost when you pull your wire. Where's the bare wire, guys? No, the same one, same one.
All right, great. So why don't I do this? Since you're already putting a filter in, what's your strategy? What's your next step after putting a filter? Are you going to do just cutting balloon, panel, anything else? What do you want to do, especially in the IVUS? Anybody wants to do rotational, orbital, directional, shockwave?
Give me a new one.
When there's no data, I guess, on all of these. What's your experience on doing this venous graft and anastomosis? Dr. Karachi.
No, I think just ballooning would be the way to go. If you can do all that, it's just the character of that vessel and that outflow. I'm worried about anything being knocked off in that situation. So there's a lot of benefits, everything you described. Just for me, that seeing that flow in that graft and all that, the target would be to get that open, the distal circulation open with the least risk of embolizing possible. She doesn't have a wound, it's rest pain. If you send that sand or powder down into foot, if it exists, because I'm not convinced the filters are fantastic, but they don't catch everything.
Correct.
You still have issues afterward, and you hate to take someone with breast pain or pain of some sort and put them to a more critical level.
Dr. Abe?
Needle social.
Dr. Babe?
The plaque on IVUS looked fibrotic, so I would just try to stay and treat just an anastomotic lesion, not going into the perineal itself, because I think then there is a mass. It's just 360 degrees of calcium there, and I would just do cutting balloon, see how that looks. We know from coronary wall that when we treat an anastomotic lesion with the bypass grafts, especially if it's just freshly done bypass, balloons are, have a pretty good result. And we do stent. This one is pretty old, so I hope you can get away without stenting, but I would just put the filter as he did and do cutting balloon and see what I get, and then decide how to proceed further.
So I wanted to ask a question if anybody on the panel would use a serenator balloon for this, but my go-to in an anastomotic lesion is plain old balloon angioplasty. Now, whether you marry drug with that or not, that's fine. But these lesions respond well, we know, to balloon alone or some sort of serenator, cutting balloon, et cetera. And I would use stenting for bailout. I agree with Fadi that this is under pressurized and that these are matched vessel sizes. So I don't think you have any problem putting 4.0 stent across that anastomosis to bail out if you screw it up.
Right. This patient is in trouble. I mean, I think it's absolutely the right thing to treat this patient. It's a single vessel runoff or a stagnation of blood flow. You need to do something. So risk versus benefit here. The benefit way outweighs the risk in this patient. And the good news, I think, in this lesion is you can pretty much use anything from simple balloon angioplasty to atherectomy to specialty balloons and end up with a good result there for that patient, because it's a relatively short lesion. It's not heavily calcified if we're talking about just anastomosis. So no matter what you do, you're going to end up, knock on wood, hopefully with good results. I will say that the NAV6 catheters, they're NAV6 filters, they're excellent filters. They're laser cut holes, and you just have to be prepared for clumping of a lot of a material. If there's a lot, I don't think there's be a lot of material here, and I would take that into consideration before putting a filter for those patients. I mean, you can see here that the vessel is too small, and that filter is going to be really, really snug. So also pros and cons to each approach. Anybody would not use a filter here? I mean, I'll be concerned just being up and over with a long sheath, and something happens and you have to bail yourself out. I'm not arguing against putting a filter, but is it really such a terrible thing not to put a filter?
Every time I do these TBL lesions and I try to rush and I don't put a filter, I pay for it dearly. I don't know why. I don't know if it's bad luck or what. I was not going to use a filter in the event of time, but I got convinced that let's do what probably safer.
Right.
But Tell me
Like-
about the filter. Should we
With
just
one-
in the panel? Should we just balloon and see how it looks, or should we use a cutting balloon, a scoring balloon?
We can ask for a consensus. Dr. Lee, what do you think?
Yeah, I
Got
mean,
it?
I think you can do anything. Honestly, I would avoid like a rotational, or
Interesting.
blathyrectomy here just for the embolic risk.
Right.
I would start maybe with a balloon and just see if it expands or
Interesting.
not. If it doesn't, then maybe go to a cutting balloon. I will say my use of filters has
Fluid
dropped a
safe.
lot since we've had such better thrombectomy catheters with penumbra. I know I can go down there and probably suck anything out. If it really does embolize, I think the risk is pretty low.
No.
And then
Fluid?
even with Rotarex, not here, but above knee type stuff. I feel like we have a lot more tools available.
Yeah, that's I was gonna say that'll be the best tool here. It's not rotational, it's forward going, it's a catheter over the wire, so there is no rotational aspect of it, so you cannot really injure from a mechanical standpoint. That would have been my choice. I think the safest from a practical standpoint
And has
would be laser
aspiration
atherectomy.
with the Orient has the aspiration aspect of it.
Yeah, the new one. Yeah.
With one vessel runoff, any atherectomy in this particular situation is potentially you can create embolic debris down, and then removing this. It's a good thing. I totally agree that filter should be there, and if it gets full and you see that you have no flow through this full filter, no matter what you do, then the good trick is to use penumbra. You just advance penumbra, suck it out, and actually pull the filter into the penumbra and remove it as a unit. That helps you actually decrease the embolic debris.
All right.
But if you close this artery and distal embolization, and if this patient is diabetic and doesn't really have any collaterals, that's a real disaster at the end of the case. And sometimes you can't go all the way distal and suck out all this clot from every single small vessel. So that's why I think it's very important to put the filter up front so you would protect something.
So I agree with you, but just to be a devil's advocate here, I mean, you're really protecting a branch out of the vasculature. Look how many branches that this vessel has. I'm not disagreeing with that. I think, but you just have to keep in mind that you're really not protecting all the circulation with just the filter being in one of those branches, which is albeit the distal perineal artery, but you're not correct. You're not protecting all those branches. And with atherectomy devices, they've done this even with the F6 filter, right? They saw there's basically clumping of material that's smaller than the RBC because of how effective it, at least for the F6 filter. It's smaller than the RBC size, but there was clumping of the material there. So again, I'm not arguing against it. I'm just saying, you just need to be cognizant of what you're protecting when it comes to these cases.
Yeah, you're protecting the highway basically. That's the only way.
Sometimes the feel-good
Okay,
factor.
so you need to let me be referee. So this end of the table right here, these last two, we feel it is absolutely mandatory to use a filter in this case. Anybody who's starting out doing angioplasty on single vessel disease and does not use a filter is committing suicide, because what happens here is limb loss and amputation. So the distal vasculature, the capillary bed, no matter what aspiration tools you have to remove debris distally, you cannot get out of this capillary bed. And if you fill those full and snowplow those full of trash, junk, and andouille sausage, you cannot get that out. So there's people that have had that anecdotal experience and they've seen that. And I know we shouldn't sit here and talk about anecdotal experience. We should talk about data. But after all, we're talking about filters, which we don't even have any data for either. So I can tell you, being 60 years old, I do not do single vessel runoff without filter, period.
Well,
So that's my thoughts.
the good thing about PAD is we have enough liberty because we have minimal data, so we can do whatever we want to do and hopefully do the right thing.
No data.
So Jose, can you just show us some final thoughts and pictures and see where we are right now?
I don't see it yet.
Yeah, so we did a scoring balloon. Let me show the picture. Go back. Play it. I mean, you still have that filling defect right at the anastomotic lesion. So, I'm thinking on a stenting. What do you guys think? A drug-coated stent.
Let's ask the panel. Dr. Karachi, let's start with you. What do you think? Stent? No stent? Leave it?
What size balloon was used?
You said 3.0.
Upsize your balloon.
I think that's too small.
Yeah, it was a scoring balloon. So the
Dr.
native
Saab, you
vessel
wanna-
there is 3.0.
Yeah, I mean, I think that even angiographically, to my eye, I don't know what everybody else thinks, but this was too small. I think you can
You-
you can be
you wanna
aggressive
use a
with a little
bigger
bit
one?
with a larger balloon and see what you end
Okay,
up
let's
with.
get let's get a 4.0 non-compliant.
Anybody
please.
else has any other thoughts?
Yeah, same thing. How would you probably a 4.0 balloon and hold it?
Okay.
Did your balloon go up, Jose? When you inflated
it did.
the balloon to how many atmospheres did you do?
Of course it.
It did. Okay. You
yeah,
can. I
yeah.
would sit again and see what
It
you
was a
got.
scoring
But
balloon.
easier. Thing to do would be just take a larger balloon and see how that looks.
Yeah, it looked okay, but you know what? Let me follow you guys' advice since we still have a filling defect. Let's put a short 4.0, 8 or 12, whatever you have there.
Jose, do you have final pictures before we move out?
I'm very glad that I have a smart panel there. We went up with a 4.0 short non-compliant balloon, and this is our final result. We're doing IVUS right now. Play, please.
We'll do a quick
Next.
IVUS and
No,
then we
no.
go to the next case.
Yeah. Just bear with me, guys, until I get the right film. Don't floor, please.
Can you show us the IVUS?
Yes, we're going to show you the IVUS now. That's the angiogram. That filling defect that we had in the anastomosis is completely gone. There's a little lesion distally, but I'm hesitant on treating it. The more you balloon a tibial vessel, the higher the restenosis rate. And I don't want to injure this vessel more.
Okay.
But let me show you the IVUS now. Can we focus on the
you see
IVUS,
the
please?
IVUS? Okay, good. So this is the pullback. As you can see, this is, because of the filter, the flow is not good. So that's why you see something black here. But this is like usual finding in this setting. And as you can see, we are pulling back. This is a arterial part of this. You see some dissection here. See, this is a flap because we use full balloons. So, but it's not like, horrible dissection, I would say. We just bring back here, and then this is an osmosis site. It looks much better here, and then now it's in the graft.
All right, beautiful, awesome. All right, thank you so much, everyone, for a beautiful case. Well done, good conversation.